Hello, my dear students. This is Dr. Rohith Daniel from DocTutorials. This session is NEET PG 2020, where we'll be discussing 20 most important MCQs that we expect for the upcoming NEET exam. Before we go into the discussion of these 20 MCQs, I know all of you would have heard the news that our NEET PG exam has been postponed. This is mixed news, I would say. It is a little bit problematic. Why? Because this will cause a little bit of interference with your current momentum. That is the only problem. You may feel that, okay, there is some more time, so let me take a few days break. So this is the only mistake that you can do. Please remember that don't lose your momentum. Keep studying. Don't think that I'll keep on, I'll take a few days break and then I'll come back to studies, because once you lose your momentum, it is very difficult to get it back. The advantage is two things. One, obviously, you are going to get a little more time for your preparation. You will get few more days for putting in more revision. And if you have not touched upon any particular subject, you can always go and learn it. Second thing is that the really bad system of two shifts is gone now. You have only one shift. This means that whatever hard work you put, the result is not going to depend on luck, because one shift, probably the students would be a little bit unlucky because of all the process that takes place while calculating the marks. So that is gone now. That is an advantage for us. So anyway, let's start with our discussion. I think many of you would have already taken the question and answers test yesterday itself. Yes, Anuj, good evening, Anuj. Yeah. So we'll discuss the questions one by one. So the chat box is open, and if you have any particular doubts, you can always ask me there and then there itself. I am willing to clear all your doubts. PKD is saying that he's running out of patience. Please don't do that. This is a time where you'll have to keep your focus, because it is very easy to get disturbed and to lose your momentum. Don't do that. Keep your focus and keep studying hard. Okay. All right, we'll start with the first question. A 10-year-old child presents with pain in her left thigh for 3 months. She also complains of intermittent fever. On examination, there is a swelling in the mid shaft of femur. The X-ray is given below. What is the probable diagnosis? So let's see. This child is 10-year-old and there is intermittent fever and there is a swelling in the mid shaft of femur. What does mid shaft indicate? It means that the tumor is in the diaphysis, isn't it? So these are our clues. So let's look at the options one by one. Can it be osteosarcoma? The age group of osteosarcoma is 10 to 20 years. But where does it affect? It primarily affects the metaphysis. And the chance of intermittent fever is also less. Can it be giant cell tumor? The common age group of giant cell tumor is 20 to 40 years. And which is the site that it affects? It affects the epiphysis. It affects the epiphysis. Then you have the Ewing sarcoma and chronic osteomyelitis. Remember, both these tumors can have intermittent fever. That is, both Ewing sarcoma and chronic osteomyelitis can present with intermittent fever. Ewing sarcoma is the tumor that can present as a infection clinically. Okay, but what is the difference? Ewing sarcoma affects the diaphysis and chronic osteomyelitis usually affects the metaphysis. So probably the diagnosis is Ewing sarcoma. Let's look at the X-ray and confirm. Yes, almost all of you have typed in the right answer. You can see here there is this kind of lamellar periosteal reaction, which is also called as onion peel periosteal reaction, which is characteristic of Ewing sarcoma. So that is our answer. Yes, Anuj, Shreyas, all of you are absolutely correct. It is Ewing sarcoma. Okay. So I'll just quickly show you the X-ray findings in the other tumors. Okay. So this is your osteosarcoma, which I told you occurs in the metaphysis, isn't it? It occurs in the metaphysis and it presents with two interesting periosteal reactions. Okay. So here you will see that there is this fine lines that are coming out of the bone. What do you call this? This is what is called as the sunburst appearance. Sunburst appearance. Or in some cases, they will have another kind of periosteal reaction where you find this triangular kind of bone formation adjacent to the cortex. This is what we call as Codman's triangle. So which are the two periosteal reactions? Either we can get sunburst appearance or we can get Codman's triangle. This is what you see in osteosarcoma. What about this? This X-ray is probably the most commonly asked tumor in orthopedic exams. Yes, so what you see here is a epiphyseal lesion, isn't it? What you see here is an epiphyseal lesion which is expansile, It is affecting the distal end radius and it has classical appearance of what? The soap bubble appearance. This is your soap bubble appearance. And what is the diagnosis? Yes, excellent guys. The diagnosis is GCT or giant cell tumor. Okay. And what is the third option? This is what you call your chronic osteomyelitis. Why? The diagnostic feature in chronic osteomyelitis is a piece of dead bone, which is called your sequestrum. Now, how do you diagnose sequestrum on an X-ray? Remember, sequestrum is a piece of dead bone. It is a piece of dead bone, and dead bone is always sclerotic. What does sclerotic mean? Sclerotic means you can see this piece of bone is whiter. It is whiter than the surrounding bone. So this is sclerotic piece of bone. This means that there is no vascularity or it is dead. This dead piece of bone is called a sequestrum. This is your classical appearance of your chronic osteomyelitis. This is chronic osteomyelitis. Okay. So this is how you answer this question. Next question. A 35-year-old male presents with back pain after lifting a heavy stone at a construction site. His MRI shows intervertebral disc prolapse at L4, L5 level. Which nerve root is commonly affected in this condition? So what is the answer here? I think this was a kind of a difficult question because I looked at the test and many of you have marked this answer wrong. What is the answer? Yes. Anuj, you are correct. It is L5. L5. So whenever you have a disc L1, L2 or L2, L3, the second one, if there is L1, L2 disc, L2 nerve root will be affected most. L2, L3 disc, L3 will be affected most. Why does this happen? I'll show you. So this is a very simplified diagram of two vertebra with a disc in between. So this is your L4 vertebra, this is your L5 vertebra, and the disc between L4 and L5 is your intervertebral disc. Okay. We know that the spinal cord would end at the lower border of L1. So this is your spinal cord. Spinal cord will give off your spinal nerves. The spinal nerves will come like this and go like this. So this spinal nerve root that comes and goes under the L4 is your L4 root. This is your L4 nerve root. And this one that comes and goes under the L5 is your L5 nerve root. Okay. Now, if you look here at the level of L4, L5 disc, there are two nerve roots, isn't it? There is one nerve root that is exiting here before the disc. This is your exiting nerve root, and this nerve root is actually passing through or passing close to the disc. This is what we call as the traversing nerve root. Okay. So you have the exiting nerve root and the traversing nerve root. Now, what happens in IVDP? See, what will happen is that this disc will get prolapsed. When the disc gets prolapsed, it will go and compress the traversing nerve root. It will compress the traversing nerve root, which is L5. So how do you remember? There is a mnemonic for it. Exiting nerve root will escape the compression. Traversing nerve root will get trapped. Okay. Always remember, exiting nerve root will escape. Traversing nerve root will get trapped. So at any disc level, say it is L1, L2, L2, L3, L4, L5, L5, S1, whatever it may be, the second one. So if it is L4, L5 nerve root, L4 is the exiting nerve root, L5 is the traversing nerve root. So always the second one is going to get trapped. So here the answer is L5. Remember, the traversing nerve root, that is the second one, is what we always be involved. Okay. Yes, correct, Anuj. You are right. All right. Question number 3. A 70-year-old lady presents with fractured neck of femur after a fall. There is no history of osteoarthritis of hip, which is the ideal treatment for this lady. I think most of you have gotten this answer right. What is the answer? It is hemiarthroplasty. Yes, hemiarthroplasty. Remember, there is a particular flow chart where we use for deciding the treatment of fracture neck of femur. So this is that protocol. Remember, for treating fracture neck of femur, we take two things into account. One is the age of the patient and second is presence or absence of osteoarthritis. Age and presence or absence of osteoarthritis. Okay. So if the age of the patient is above 65 and there is no osteoarthritis, we do hemiarthroplasty. If the patient's age is less than 65 and there is no osteoarthritis, we fix the fracture. But if there is osteoarthritis, don't look at the age of the patient. It can be above or below 65. It doesn't matter. If there is osteoarthritis, we have to do total hip replacement. This protocol is something that you have to learn for your exam. So let's look at the question once again. This is a 70-year-old lady. So obviously the age is above 65 years and there is fractured neck of femur and there is no history of osteoarthritis. So obviously, looking at the flow chart, the treatment that will follow is hemiarthroplasty. Okay, hemiarthroplasty. Yes, Indu, Anuj, Vishal, PSPK, Shreyasri, all of you are absolutely correct. This is hemiarthroplasty. Next question. A 35-year-old male presents to the OPD with complaints of pain and swelling in both hands. On examination, there is arthritic changes in the distal interphalangeal joint of hands. He gives a history of skin lesions for which he has been taking treatment for the last 2 years. What is the most likely diagnosis? So what is the answer here? So see, the key point here is involvement of the distal interphalangeal joint. So whenever there is involvement of distal interphalangeal joint, remember there are two things you have to remember. DIP arthritis. DIP arthritis means either it can be plain or simple osteoarthritis. Osteoarthritis. If you look at the hands of your grandparents and all, especially grandmothers, they may have the swelling and arthritic changes in the distal interphalangeal joint. So that is simple age-related osteoarthritis. Second possibility is psoriatic arthritis. Okay, second possibility is psoriatic arthritis. So these are the two things you have to keep in mind. Can it be rheumatoid arthritis? It can never be rheumatoid arthritis. Why? Because DIP is classically spared. If the DIP is involved, it can never be rheumatoid arthritis. Okay. Can it be pemphigus associated arthritis? No. Here again, pemphigus does not have specific arthritis that it causes, but it can be associated with rheumatoid arthritis. Again, in rheumatoid arthritis, DIP is spared. Can it be Reiter syndrome? No. Reiter syndrome is a reactive arthritis, which is characterized by three things, isn't it? You have uveitis or conjunctivitis, plus you have urethritis, and you will also have arthritis, isn't it? And when there is arthritis, there will be involvement of the larger joints, especially the knee joint or the ankle joint. Okay, these joints would be primarily affected. DIP is not affected. So here the patient also has skin lesions. So the answer is obviously psoriatic arthropathy, psoriatic arthritis. I think all of you have gotten this correct. Yes, Anuj is correct. Vishal, Kumar, all of you are absolutely correct. Yes, Anuj, even psoriatic arthropathy is associated with HLA-B27. Next, which injury can cause the deformity shown in the image below? Remember, for the last few years, we are seeing that most of the papers have a question on a deformity. They will give you an image like this and they will ask you to identify the deformity and ask a question related to it. So what is this deformity? See, for assessing any deformity, you have to do two things. What is that? First, you look at the point of deformity. This is the elbow. The deformity is at the elbow. And look here, whenever there is a deformity, you have to look at the orientation of the distal part. Don't look at the proximal part. So if the deformity is at the elbow, look at the direction or orientation of the forearm. If the deformity is at the knee, look at the orientation of the leg. Okay. So here look at the forearm. The forearm is deviated inwards towards the body. So this is your varus deformity. And because this deformity is occurring in the elbow, this is your cubitus varus deformity. Cubitus varus deformity, which is also called as, yes, absolutely correct, guys. It is your gunstock deformity. Gunstock deformity is the most common complication of which condition? Malunion of supracondylar fracture of humerus. Yes, most of you have got this correct. The answer is malunited supracondylar fracture of humerus. And remember, this is another X-ray or clinical image that they can ask. This is just the opposite of what we just studied. What is this deformity? Can you tell me? What deformity is this? Here you can see the elbow. There is a problem at the elbow and can see that the forearm is deviated away from the midline. What would be this? Yes, this is just the opposite of cubitus varus, which is cubitus valgus. Cubitus valgus. Okay. So this is cubitus valgus deformity. Remember, it occurs in association with non-union of lateral condyle fracture of humerus. Okay, this is the reason for cubitus valgus. And remember, there is a nerve injury that can occur because of cubitus valgus, a nerve that passes along the medial aspect of your elbow. What is it? It is ulnar nerve. So you can get something called as a tardy ulnar nerve palsy. All these are important previous year topics. Okay. Cubitus varus is malunion of supracondylar fracture. Cubitus valgus is non-union of lateral condylar fracture of humerus. And in cubitus valgus, you get an additional problem, which is tardy ulnar nerve palsy. Tardy means slow or lazy. It's called tardy because ulnar nerve injury occurs over a period of time. It may take few months or years for nerve injury to occur. That is why it is called tardy ulnar nerve palsy. Yes, Manas, you are absolutely right. Next question. I think this is a very easy, straightforward question. A fracture at which of the following sites of humerus can result in a wrist drop? Nowadays, we are seeing more and more match the followings and image-based questions like this. So what is the answer? So what is the site A? Site A is the surgical neck of humerus, and which is the nerve that is associated with it? The nerve that winds around the surgical neck? Yes, it is your axillary nerve, isn't it? Axillary nerve. And side B is your mid shaft, side around your, what area is this? Yes, all of you are correct. This is the area of spiral groove, isn't it? Spiral groove. Spiral groove. And the nerve associated here is the radial nerve. D is your medial condyle. Medial condyle, and medial condyle is associated with your ulnar nerve. C is your lateral condyle. Lateral condyle fracture non-union can result in tardy ulnar nerve palsy. We just learned that, isn't it? Tardy ulnar nerve palsy can occur here. So the patient has wrist drop. If the patient has wrist drop, which nerve is involved? It is your radial nerve. Yes, Indu, Vishal, Shreyasri, all of you are absolutely correct. This is wrist drop occurring because of radial nerve injury, and the site of injury is site B. Site B. You never know, the same question can be asked. They might they may say that there is deltoid paralysis. If there is deltoid paralysis, then it would be site A. Maybe they will say that there is a claw hand deformity. And if it is an acute injury, then it is probably a medial condyle fracture, which is site D. Or sometimes they can say that injury occurred 2 years back. Now the patient has a paresthesia of the ulnar aspect of the forearm, or there is a claw hand deformity. This is a late onset ulnar nerve palsy or tardy ulnar nerve palsy. The site is probably site C. Okay. Next question. A 55-year-old lady presents to the OPD with complaints of polyarthralgia for 10 years. She has developed deformities of hands over the last 2 years, which is shown below, which is shown in the image below. What is the most probable diagnosis? See, whatever questions we are discussing here are very, very important, because these questions and the topics per se has been asked multiple times in the past few years. So let's see what is the answer here. This is a 55-year-old lady presenting with polyarthralgia. So polyarthralgia itself means that there is some kind of arthritis in this patient. So what could be the arthritis here? Can it be Reiter syndrome? Reiter syndrome, we know that the knee joint or the ankle is primarily involved. So it is unlikely to be Reiter syndrome. Can it be osteoarthritis? Osteoarthritis in the hands can occur, but at an elderly age, usually after 60 years. So the chances relatively less. Can it be psoriatic arthropathy? That can occur, but their DIP is primarily involved. What about rheumatoid arthritis? Let's look at the clinical image here. There are two very interesting deformities that you see in the hand. One is seen at the knuckles. See what is happening at the knuckles? All the fingers are deviated towards one side, isn't it? It is deviated towards the ulnar bone. Here also there is this medial deviation or ulnar deviation. This is what we call as the ulnar drift. Ulnar drift of fingers at the MCP joint. Okay, that is one sign. Then what do you see? What is the shape of the thumb? There is an Z shape, isn't it? Z deformity of thumb is also seen. So there is an ulnar drift of fingers at the MCP joint and Z deformity of the thumb. And both these are classical findings of rheumatoid arthritis. Rheumatoid arthritis. Grace, Indu, Vishal, yeah, Divyan, Shreyasri, all of you are absolutely correct. This is rheumatoid arthritis. Okay. Next, a current favorite among our examiners, very often asked. A 35-year-old male sustained injury to his right knee after a road traffic accident. His X-ray is given below. What is the treatment of choice in this situation? So tell me, what is this fracture first? What do you see here? This is an X-ray of the lateral view of the knee, and this is your femur. This is the femur here. This is the tibia here. And you can see that the patella is here, but something has happened there, isn't it? there is a fracture of the patella. There is a fracture of the patella. But simply saying fracture of the patella is not going to help you. You have to describe this fracture. What kind of fracture is this? This is a displaced transverse fracture. Okay. There can be different types of fracture. There can be an undisplaced fracture. There can be a comminuted fracture. The treatment would depend upon the type of patellar fracture. The most common type of fracture we encounter is something like this, a displaced transverse fracture. And how do you treat it? How do you treat such a fracture? It is treated by tension band wiring. Tension band wiring. Okay. Can you do a fixation with plate and screw? No. You cannot do plate fixation. It will definitely fail. You don't have to do a total knee replacement also. Can you use a cylinder cast? You can use it, but only for an undisplaced fracture. Okay. For an undisplaced fracture of patella, you can use a cylinder cast. For all other conditions or a transverse displaced fracture like what you see on the X-ray, you need to do a tension band wire. Okay. Yeah. So Vishal, Shreyasri, Indu, absolutely correct. This is a patella fracture which is displaced, which can be treated with tension band wiring. Remember, tension band wiring is a type of K wiring. Okay. This is a type of K wire fixation. So sometimes in your paper, the examiner may not say that it is a tension band wiring. They may give an option of K-wire fixation. If there is no tension band wiring and only K-wire fixation is there, then you can choose that. Okay. Next question. Identify the instrument shown in this image. Can anyone tell me? Anuj is asking how to differentiate between bipartite and patella and fracture patella. At the end of this session, I'll teach you. Okay. So, what instrument is this? See, the key factor to see here is this. This is a stand-like instrument or a device, and where you can see multiple pulleys. These are actually pulleys. Okay. These pulleys are used to thread a rope around them like this, and you can apply traction to it. There can be traction application using this. And this is a primary device used for skeletal traction. We give skeletal traction using this device, and this is what we call as Bowler-Braun splint. Bowler-Braun splint. Okay, so whenever you see a stand with pulleys, immediately think of Bowler-Braun splint. Okay, so Divik is saying that Kumar is saying that there are 3 pulleys. Sometimes there can be 4 pulleys also. Okay, so don't worry if there are 3 or 4 pulleys. If there are multiple pulleys like this, the stand should be Bowler-Braun splint. Okay. So these are the images of the other options that were given there. So this is your Thomas splint. I think most of you would already know this. This is used for fracture shaft of femur. What about this splint? This is your Volkmann splint, which is also called as the turnbuckle splint. Turnbuckle splint. Okay, this is also called as turnbuckle splint, and it is used for a condition called as Volkmann ischemic contracture. Is used for Volkmann ischemic contracture. This looks like a cock-up splint, but the key difference is this. There is this turning mechanism that is provided there. The idea is when you turn that knob there, over a period of time, the contracture or the deformity will get corrected. Usually take months for correction. So slowly you can turn that and correct the deformity. This is your turnbuckle splint. Finally, we have Buck's traction, which is commonly called as skin traction. Skin traction. And skin traction is used for which condition? Usually for fracture neck or femur. In skin traction, you apply bandages directly on the skin like this and you apply traction. Only problem is that you cannot give more than 1 or 2 kgs of traction with skin traction. Otherwise, it will injure the skin. So for heavier tractions, we have to use skeletal traction where we put a pin inside the bone, and that is where we use the Bowler-Brown splint. Okay. All right, very, very easy question, but probably the most commonly asked splint in the history of your NEET exam. In which nerve injury is the splint shown in the image used? So what splint is this? This is your dynamic cock-up splint. This is your dynamic cock-up splint, which is used for wrist drop, isn't it? Wrist drop, which is seen in association with radial nerve injury. Radial nerve injury. Yes, all of you are absolutely correct. Vishal, Anuj, Warrior, all of you are correct. This is cock-up splint used for radial nerve injury. So these are the other important splints that may come for your exam. One is this knuckle bender splint. This is used for ulnar nerve injury. Ulnar nerve injury, where the patient will present to you with what deformity? The patient will have a claw hand deformity. This is your aeroplane splint, which is used for Erb's palsy. This is opponent splint, which is used for ape thumb deformity. Ape thumb deformity, and this is seen in median nerve injury. And finally, this is the foot drop splint used in foot drop, which is useful in common peroneal nerve injury. Common peroneal nerve injury, again, is a very important topic. Remember, common peroneal nerve injury is usually associated with fractured neck of fibula. And these patients will have foot drop. And patients with foot drop will walk with an abnormal gait called high stepping gait. High stepping gait. Okay. All these are commonly asked questions. Okay. All right. Next question. So for this test, we had to match the following questions. I think most of you found the match the following questions difficult. So let's discuss this. So this is a match the following where you have to match the particular nerve injury with the signs associated with them. Okay. So what is this pin? Pin is your posterior interosseous nerve. And what is the function of posterior interosseous nerve? It is primarily a dorsiflexion of the fingers. So when the pin is paralyzed, pin is actually a motor branch of radial nerve, isn't it? So when the pin is paralyzed, the patients will have something called as finger drop. That is the answer. Then we have AIN, which is the anterior interosseous nerve, which is a deep branch of median nerve, and it primarily supplies flexor pollicis longus, flexor digitorum profundus lateral half, and pronator quadratus. And when there is a paralysis of anterior interosseous nerve, we get something called as a Kilo-Nevin sign or the OK sign. Okay. Kilo-Nevin sign or OK sign. If there is an ulnar nerve paralysis, you get something called as a Fromen sign when you do a book test. I'll show you the image later. And whenever there is a median nerve paralysis, you get something called as a benediction sign. So the correct answer would be C, isn't it? A2, B1, C4, D3. So this is our correct answer here. I'll show you a few images. So this is your Kilo-Nevin sign or the OK sign. So if you want to test AIN, you ask the patient to make a beautiful O like this, OK like this. If the AIN is paralyzed, anterior interosseous nerve is paralyzed, the patient won't be able to do this and the patient would instead keep the fingers like this because of FPL paralysis and the FDP lateral half paralysis, which all both these muscles are responsible for flexion of the thumb and flexion of the distal interphalangeal joint of the index finger. So the patient will not be able to do this. Instead, the patient would keep the hand like this. Okay, this is your OK sign. In benediction sign, you ask the patient to flex the fingers. If the median nerve is paralyzed, usually the index finger would pop up like this. The patient won't be able to flex it. This is called pointing index. This is what we usually see. But sometimes the patient won't be able to flex the middle finger also. So both middle and index finger would be held up like this. And this looks like the gesture made by Pope or Christian priest to bless the people. So that is why it is called as the benediction sign. Benediction sign. Okay, this is for median nerve, and this is your book test. Book test is a test for your adductor pollicis. Remember, adductor pollicis is your only thenar muscle which is supplied by ulnar nerve. All the other three thenar muscles are supplied by median nerve, isn't it? So adductor pollicis is supplied by ulnar nerve. Basically, what you're doing is that you ask the patient to keep a book between the thumb and the hand, and the examiner will pull it in the opposite direction. If the patient has weakness of adductor pollicis because of an ulnar nerve paralysis, the book would slip out of the patient's hand. Okay. Now, if that occurs, that is called as a positive book test. Positive book test. Now, sometimes what can happen is that the patient would subconsciously will try to hold on to the book. How? By flexing the IP joint. His adductor pollicis is gone. Adductor pollicis is not working. But FPL is working. Why? Because FPL is supplied by the anterior introitious nerve. That is okay. So he will try to hold on to the book by using his flexor pollicis longus. So you see this flexion of the IP joint of thumb. This is what we call as the Fromen's sign. Fromen's sign. Okay. So all these are important, very important question for your exam. Next, another very, very favorite topic among your examiners. Not true about achondroplasia. So what is the correct answer here? Can there be a proximal migration of midpoint of body? Yes, that can be seen. Is inheritance autosomal dominant? Yes, that is also correct. The primary problem here is FGFR3 mutation that occurs in chromosome number 4. It is autosomal dominant. Starfish hands are seen. That is also correct. Along with starfish hands, you will also see something called as trident hand, where there will be hand like this, like a trishul. That is trident is trishul. Hand would be like this. Okay. And there will be brachydactyly or short fingers would be there. Will there be any impaired sexual development? No. So this is the not false statement here. That is the answer. Remember, achondroplasia, IQ will be normal. Remember, and sexual development will also be normal. These 2 points have always been asked in exam in true or false statements. Either they will say that IQ is deficient, or they will say that sexual development is deficient. Nothing like that. They are normal people, only short stature and some other physical differences are there. Okay. Another two important points are X-ray findings. Okay. X-ray findings. Remember, X-ray findings are bullet nose vertebra. There can be bullet nose vertebra, or when you take an X-ray of the pelvis, you get something called as a champagne glass pelvis. Champagne glass pelvis. Okay. So these are the important MCQs here. Read achondroplasia thoroughly. Very, very often asked. Okay. Which is not a part of McCune Albright syndrome. So McCune Albright syndrome is one of the most commonly asked orthopedic syndromes. Orthopedic syndromes are generally not asked that commonly, but McCune Albright syndrome has been asked twice in the last 5 years. Okay. So what is this McCune Albright syndrome? There are classical 3 P's, isn't it? 3 P's. What are the 3 P's? 3 P's. First P is polyostotic fibrous dysplasia. Fibrous dysplasia is a tumor-like condition affecting the bone where the normal bone is replaced by fibrous tissue. Okay. This is fibrous dysplasia. When multiple bones are affected, we call it polyostotic fibrous dysplasia. Poly means multiple, ostotic bone. Multiple bones are affected by fibrous dysplasia. Second is pigmentation. Second P is pigmentation, and pigmentation will appear in the form of cafe au lait spots. Cafe au lait spot. Okay. Pigmentation in the form of cafe au lait spots. And third P is precocious puberty or an early onset puberty, where children as young as 3, 4, 5 years can develop features of puberty. So 3 P's. What is not a part here is multiple enchondromas. I think all of you have gotten this correct. Anuj, Indu, Warrior, Grace, Stacey, very good. All of you have gotten this correctly. So this is multiple enchondromas is the odd one out here. And what is the syndrome where you see multiple enchondromas? It is Olier's disease. Okay, this is Olier's disease. Multiple enchondromas are seen in Olier's disease. That is also an MCQ. All right. Okay. Next, match the following. This is the question where only 30% of the students could get the whole match the following correct. So what was the difficulty here? So remember, different tumors in orthopedics have different kinds of surgeries. Okay. Not all tumors are treated by excision. So these 4 tumors are very, very important because they have unique kinds of treatments. Especially you have osteoid osteoma. Osteoid osteoma, if you remember, presents as a small lytic lesion, nidus in the cortex of a bone, and you don't have to operate on it. The treatment is by something called as a radio frequency ablation, where we put in a radio frequency probe exactly into the nidus using CT guidance. Then you heat up the tip of the radio frequency probe to a very high temperature. This will cause destruction or thermal necrosis of the tumor. That is all that is required. You don't have to do a big surgery at all. Then for GCT is a locally invasive tumor. Therefore, simple curettage and removal will not work. You will get recurrence. So, along with curettage, you have to apply bone cement or apply phenol or do electrocautery or something like that. This is called extended curettage. So, GCT is treated by extended curettage. What is this SBC? Simple bone cyst. This is a very mild tumor, not even a tumor, it is a tumor like cyst of the bone affecting children. Again, you don't have to do surgery. What you do is that you put in a needle into the cyst, aspirate the cyst, you will get some fluid, you throw the fluid away, and you put in steroid. You inject steroid into the cyst, and over a period of time, the cyst would heal. So, simple bone cyst is treated using steroid injection. And finally, you have enchondroma, which is a very, very mild benign tumor. Mostly, we don't even need to treat it. If it is very symptomatic, you can treat it by doing a simple curettage, where you just open up the cavity and just curate out all the contents, and that's it. The lesion would heal. Enchondroma is one. So it is A2, B3, C4, and D1. The correct answer is option number D. Okay. So please learn all these important tables as well. You never know which one is going to be asked. I think last year for INACT, we had a similar question where on one side we had tumors, and on the other side we had the various genetic mutations responsible for all of those tumors. Okay. So these kinds of tumor tables are very important. All right, next question. A 18-year-old male who has been on long-term steroids for bronchial asthma presented with pain of the right hip for the last 6 months. On examination, there is a restriction of rotations of hip joint. X-ray shows crescent sign. What is the diagnosis? I think more than 90% of the students who took the test got this answer correct. I was very happy with that. So what is the answer here? Excellent, guys. It is avascular necrosis of femoral head, isn't it? So whenever in your question there is this long-term steroid and there is hip pain, so long-term steroids plus hip pain equals avascular necrosis of femoral head. Okay. So always remember, this is a mnemonic for you. Long-term steroids plus hip pain is always avascular necrosis of femoral head. Okay. Now, what is this avascular necrosis of femoral head? I'll quickly explain that as well. So let me draw the proximal femur here. So this is our proximal femur. We know that there is blood supply going into the head like this. Now, imagine a condition where there is a fracture of the neck. What happens when there is a fracture of the neck? The blood vessels are cut and the blood supply to the femoral head will go down and there will be necrosis of femoral head. Okay, this is what happens after a fracture neck of femur. Now, imagine a condition where there is no fracture, yet traumatic. There is no fracture, but due to some unknown reason, the blood supply completely disappears to the femoral head. So basically, this is an idiopathic condition. We do not know the mechanism or exact cause. Idiopathic condition where the blood supply is completely lost. So what happens to the femoral head? It will undergo necrosis. There will be death of the bone and there will be necrosis of the bone. What happens when there is necrosis of the bone? The bone is going to become weak, isn't it? Now this is the hip joint. So when the patient starts walking, what will happen? The patient is actually weight bearing on this weak, destroyed or necrotic bone, isn't it? So when the patient starts walking, the femoral head, the weakened area would collapse like this. This is your avascular necrosis of femoral head. Look at the X-ray here. Can see the femoral head has completely collapsed, isn't it? Exactly like what I showed you. The actual shape of the femoral head would be something like this. It has completely collapsed and it has flattened. Now we know that we have the acetabulum here. Acetabulum is nice, beautiful, it is spherical, but the shape of the femoral head is abnormal now. Now what happens when the patient keeps on walking? There is this friction between the femoral head and the acetabulum, which will result in osteoarthritis. There will be osteoarthritis in the hip and the patient will develop severe pain, stiffness, limping, everything would be there. So this is avascular necrosis. Now we said that is idiopathic. We do not know the mechanism, but there are certain risk factors that we know. There are certain risk factors that can develop, that can result in avascular necrosis. The most important risk factor is steroid intake, especially long-term steroid intake is the most important risk factor. Other causes or risk factors can be alcohol intake, can be retroviral drugs, or other causes, sickle cell anemia. These are the important risk factors. Most important is steroid intake. Okay. Now, in the question, they have mentioned something called as crescent sign. What is this crescent sign? See, in the initial stages of avascular necrosis, when a small area becomes avascular and it collapses, it forms a crescentic area like this on an X-ray. This is called your crescent sign. Yes, Anuj is saying that it's called Chandler's disease. Yes, absolutely correct, Anuj. This condition is also called as Chandler's disease, avascular necrosis of the femoral head. Okay. So let's go look at the question once again. 18-year-old male, long-term steroids. There is pain of the hip. On examination, restriction of the movements of the hip is there. X-ray shows crescent sign. Okay. All these things actually point towards avascular necrosis of femoral head. Got it? Yeah. I think Indu, Anuj, Warrior, all of you have got the answer correct. Next. Identify the angle shown in the image here. So what is this X-ray? Tell me first. This is an X-ray of dorsolumbar spine AP view. So when you take an AP view, the spine should be absolutely straight, isn't it? The spine should be straight. But is the spine straight here? No, isn't it? There is a lateral bending of spine. Now, what do you call this condition? A lateral bending of spine. Lateral bending of spine is called scoliosis. Yes, this is called scoliosis. And yes, Hindu, Anuj, Shreyasri, absolutely correct. All of you are absolutely correct. This is scoliosis, and the angle used to measure scoliosis is Cobb's angle, Cobb's angle. So whenever you see a spine like this with all these lines marked and they are asking about angle in scoliosis, the answer would be Cobb's angle, Cobb's angle. Okay. I'll just quickly show the other angles as well. First is your Bowman angle. Bowman angle is used to measure cubitus varus. It is used to measure cubitus varus. It is measured by first drawing a line along the center of the humerus and another line along the upper border of the capitulum. So this angle is your Bowman angle. You don't have to worry about it too much. Just remember that when you have an angle like this in the elbow, it is Bowman angle. Bowman angle is used to measure cubitus varus in malunion of supracondylar fractures. Okay. Then in the calcaneum, they can ask, in fact, they have asked about Bowler angle. What is this Bowler angle? Bowler angle is the angle that you see here. You draw a line along the upper border of the calcaneum. Then see here, this is the superior articulating facet of the calcaneum. Now, you take the anterior most and posterior most points here of the superior articulating facet. Then you draw a line joining it. This is the Bowler angle. Even if you don't know anything about it, just remember that in the angle, in the calcaneum, the most important angle is your Bowler angle. And what happens to Bowler angle when there is a calcaneal fracture? So listen to me here. So whenever there is a calcaneal fracture, Bowler will lower. Okay, remember that Bowler sounds like lower, isn't it? Bowler, lower. Whenever there is a calcaneal fracture, Bowler angle will decrease, Bowler will lower. Okay. So angle fractures, Bowler angle. Elbow, whenever there is cubitus varus, there is Bowman angle. And finally, we have something called as Ferguson angle, which is also called as the lumbosacral angle. It's not very important for you, unlikely to be asked for you. I've just put it for you for a completion sake. Okay. So remember these three. Cobb's angle in the spine, whenever it is associated with scoliosis. Bowman angle for cubitus varus in the elbow. Ankle, Bowler angle. Okay. Next, question number 17. A 25-year-old male was admitted 2 days back in your hospital after sustaining a fracture shaft of femur from an RTA. He was planned for surgery today. However, he developed tachycardia, tachypnea, altered behavior, and rashes in the periumbilical area. What is your diagnosis? Again, this is a question often asked, and I'm happy that most of you students have got the answer correct in the test. Yes, absolutely right, guys. The correct answer is fat embolism syndrome. So what is this fat embolism syndrome? See, whenever there is an injury to a bone, especially fracture shaft of femur, the fat globules from the bone marrow will escape and can enter into the arterial circulation. In the artery, it will go to the heart, then it will go into the systemic circulation, go to multiple organs, cause mechanical as well as biochemical damage in those tissues and cause multi-organ dysfunction and finally death. This is fat embolism syndrome. So what are the features of fat embolism syndrome? I'll quickly tell you. There will always be a trigger for fat embolism. And the most important trigger is fracture shaft of femur. And after fracture shaft of femur, the second most cause would be fracture shaft of tibia. Then it can also occur in polytrauma. Okay. So in this particular question, the patient had fracture shaft of femur, but that may not be the case in your exam. The examiner may just put fracture shaft of tibia or polytrauma there. Okay. Then remember, there will always be a time delay. Okay. See, it is impossible that a patient gets fracture shaft of femur today and 2 hours later he develops fat embolism syndrome. No, it takes a little bit of time for the symptoms of fat embolism syndrome to develop, and generally it is around 48 hours. It can be 24 to 72, but around 48 hours. So here you can see there is a time delay of 2 days. Okay. Then there will always be a triad of symptoms. What are the triad? First, there will be respiratory symptoms such as there will be dyspnea, there will be tachypnea, there would be reduced SpO2 or partial pressure of oxygen. Second would be CNS symptoms, such as seizure disorder. Seizures could be there, or there will be altered sensorium, or there will be altered behavior. The patient would become very aggressive. And the third important part of the triad is the rashes. And these rashes generally appear in the anterior part of the body, in the anterior chest wall, the periumbilical area, axilla, sometimes even the lower palpebral conjunctiva. All these areas you can get rashes. But the only problem is that in Indian skin tone, it is very difficult to pick up rashes. So many a time for your question, most of the time rashes won't be mentioned. It doesn't matter. Even if rashes is not mentioned in the question, just with the other 2 points and the other points such as the fracture shaft of femur and the 2-day delay and all, you can make a diagnosis of fat embolism syndrome. So don't expect such a perfect question that I have framed for you. In your exam, the question could be a little bit twisted, or you may feel that all the findings are not there. Doesn't matter. If most of the points are pointing towards fat embolism, choose fat embolism as the answer. Okay. Yes, Grace, Anuj, Vishal, all of you have got this correct. AD warrior, yes, this is fat embolism syndrome. Next question. A 45-year-old female presented with paresthesia of the right upper limb for 3 months. Test shown in the image is positive. What is the diagnosis? What test is this? You can see that patient is doing something like a reverse namaste, isn't it? She's keeping the wrist like this in forced pronation, and she has to keep it for a period of 60 seconds to see if there is any paresthesias of the fingers. What is this? This is your phalanx test. This is your phalanx test, and it is positive in carpal tunnel syndrome. What is carpal tunnel syndrome? This is the most common compression neuropathy in the body. Compression neuropathy, where there will be soft tissue constriction or compression of a major nerve. Here you have compression of the median nerve. Another important MCQ is phalanx test is obviously an important test for carpal tunnel syndrome, but they may ask you what is the best clinical test. The best test for carpal tunnel syndrome is the Durkin test. Is the Durkin test. Okay, Durkin test is a direct compression test of the carpal tunnel, where you use your thumbs to compress on the patient's carpal tunnel for a period of 30 seconds to see if there is any symptoms. Okay, so carpal tunnel syndrome, phalanx test and Durkin test. Durkin test is the best clinical test. Another very commonly asked test is this. What test is this? Here, the examiner is standing behind a seated patient. The examiner is examining for the pulses, radial pulses, and he is asking the patient to turn to the same side. Actually, the examiner is looking for any fall in the radial pulse, or sometimes the radial pulse can completely disappear as well. What is this test? Excellent, Anuj. This is your AdSense test. This is the AdSense test, and it is positive for thoracic outlet syndrome. Outlet syndrome, and the most important condition causing thoracic outlet syndrome is cervical rib. Cervical rib, where you get a elongated transverse process, or sometimes even a fully formed rib arising out of the C7 vertebra. Okay, excellent, Indu, Shreyasri, Grace, in all of you are absolutely correct. This is for thoracic outlet syndrome. This is AdSense test. All these are very important points. Okay. Suresh is asking when will be the exam. I have no idea actually. So whenever we get some information, we'll definitely pass it on to you. So we were also thinking whether the exam is going to be postponed or not. We had this inkling that probably it's going to be postponed because NBA couldn't arrange all the examination centers on time. So we'll wait and watch. So these things you should never get it in your mind. Okay. So when the exam happens or when will it happen, how many shifts there would be, all these things are out of our control. So if you watch the interviews of Dhoni, especially when he was captain and when he was in his prime, he would always say that you focus on the controllables, isn't it? So he would always say that things are controllables and non-controllables, isn't it? So controllable things are whatever things that you are in control. That is how many hours of hard work you can put in, or or how much focus you can put in your studies, how well you have revised. All these things are controllable. Or how well you practice your MCQs. All these are controllables. Non-controllables are, okay, when the exam is going to be, where is going to be my center. These things are absolutely not useful for you at all. So forget about these things. When the exam occurs, we'll go right. That's it. Till that time, we'll focus on our studies. That's it. Okay. So please focus on controllables. Okay. Focus on controllables and forget about non-controllables. Okay. So this is very, very important. Keep a positive mind. Okay, the exam may be postponed for 10-15 days. That's it. No problem. So you can focus on your studies, keep with your schedule, and if you get extra time, you revise more. That is it. And if you have not studied any particular topic, go study that. That's it. Only thing I would like to request you is that this is a point where many students can get derailed. You might be working with real good focus and suddenly you say, oh my god, the exam is postponed, now there is no point in studying, probably I'll take 2 or 3 days rest. I have been studying for so long, I have been putting in 16 hours a day for last 1 month, 2 months, I'll take a break for 2 3 days. Don't do that. Take a break for 1 day max, 1 day, that's it. Then come back. Otherwise what will happen is that if you break your habit, then it is very, very difficult to get back to that habit again. So please, even if you are taking 1 day break, I would suggest that you read for at least 1 hour. This is very important to maintain your continuity and consistency. So there is a very famous book called Habits by James Clear. So where he gives you the steps by which you can cultivate good habits. So one point he says is that always maintain consistency. So if you are reading for NEET, even if you are taking break for a day, at least make sure you read for half an hour or 1 day, okay, or for half an hour or 1 hour. So this will keep consistency. Otherwise, once you go off track, it's very difficult to come back. Okay. So please remember that, work hard. That's all. So question number 19, which organism causes osteomyelitis in a patient with sickle cell anemia? So what is the answer here? So very, very straightforward question, isn't it? In sickle cell anemia, the most common organism causing osteomyelitis is, yes, it is Salmonella, isn't it? Remember, in chronic osteomyelitis or any osteomyelitis, the most common organism responsible is what? It is Staphylococcus aureus. But there are certain special situations where other organisms can cause infection. One is sickle cell disease. In sickle cell disease, the organism is Salmonella. Then what else? In animal bite, the organism is Pastorella, named after Louis Pasteur. Then in human bites, you get Acanella. Then what else? In IV drug users, you get Pseudomonas. Okay, so these are the other rare organisms that can cause osteomyelitis in special situations. Otherwise, 99% of the time, the culprit would be Staphylococcus aureus. Okay. Finally, so when I designed this question, I thought that this is going to be difficult, but more than 90% of the students have gotten this answer correct according to the statistics. I was going through it. So I'm very happy for that. So 40-year-old male presents with chronic back pain that has progressively worsened over the last few months. He also reports fever, night sweats, and unintentional weight loss. On examination, there is localized tenderness over the lower thoracic and lumbar spine. MRI is shown here. What is the diagnosis? So let's look at the options. Okay. First, can it be osteoporotic vertebral fracture? If it has to be osteoporosis, remember, either this has to be a post-menopausal. This should be either be a post-menopausal woman or a male above 70 years of age, because that is the age at which senile osteoporosis occurs. So 40-year-old male can definitely never develop osteoporotic fracture. Now, can it be metastatic spinal tumor? That is a possibility. Why? Because there is unintentional weight loss, there is some destruction on the MRI and all. So that is a possibility. Can it be pod spine? What is pod spine? It is TB spine. Is that a possibility? That is again a possibility because there is fever, night sweats, unintentional weight loss, everything can be in TB also. Can it be ankylosing spondylitis? Unlikely, isn't it? Unlikely. Why? Because the age group of diagnosis is usually around 15 to 35 years. The patient usually has back pain, along with there will be back stiffness, and they don't get fevers and night sweats and weight loss and all those things. Okay, so ankylosing spondylitis again unlikely. The two differential diagnoses here is either metastasis or pod spine, and just by looking at the MRI once you can actually make the diagnosis. How? So I'll show you. See, look at this MRI. So this rectangular thing that you see here is your vertebra. Okay, this is your vertebra. Here we have another vertebra here. And in between the two vertebra, we have this structure. What is this? This is the intervertebral disc. That is the intervertebral disc. Okay. Now look at this affected area. What do you see? Primarily look at the intervertebral disc. Is it normal? You can see that the intervertebral disc is destroyed. And what else is destroyed? Look again. See, the vertebral end plates can be seen here. No, it is very irregular and it is destroyed. The adjacent vertebral end plates are also destroyed. And all these white things that you see here is actually abscess. Even if you don't know that, it's okay. Intervertebral disc is destroyed. Adjacent vertebral end plates are destroyed. Okay. And these two are classical features of TB spine. TB spine. So intervertebral disc is destroyed. Adjacent vertebral end plates are destroyed. Classical TB spine. Okay. Now I'll show you another image here. What is this? See here. Here, the intervertebral disc is normal, isn't it? Intervertebral disc is normal, and you can clearly see a lytic lesion in the vertebra. There is a lytic lesion in the vertebra, isn't it? So this is your metastasis. So there is a dictum that we follow. So a good disc is poor prognosis. Why poor prognosis? If the disc is normal, it means that it is metastasis. A bad disc. If the disc is bad, we are happy because the prognosis is good. Why? Because it is TB spine. Okay. So if you don't know anything, at least look at the disc. Good disc, bad prognosis. Bad disc, good prognosis. Okay. Good disc, metastasis. Bad disc, TB spine. Okay. Now, this is your vertebral fracture. I'll show you. See this vertebra. This is the nice, beautiful rectangular vertebra. What has happened here? The vertebra has collapsed anteriorly, isn't it? Anteriorly, the vertebra has collapsed and it has taken a wedge kind of shape. This is called the wedge compression fracture. Wedge compression fracture of vertebra. This is actually a minor fracture which is usually seen after falls in osteoporotic patients. It is seen in osteoporotic patients, and generally we treat this condition using a brace called Taylor's brace. Okay. These are important points which have been asked previously. This is your wedge compression fracture. And finally, someone is asking about ankylosing spondylitis. Ankylosing spondylitis MRI is not going to be asked. X-rays can be asked. So two commonly asked X-rays are kept here. Different patients. Okay. So first is what? This is your bamboo spine. Can clearly see, isn't it? Can see that the entire vertebral column has been fused together into a single column. It looks like a bamboo tree. This is bamboo spine. And here, can you see there is this whitish calcification in the center of the spinal column. What do you call this? Yes, this is your dagger sign. These two are the findings of ankylosing spondylitis. Okay. All right. So I think we have discussed all the questions. So if you have any particular doubts, I'll clear it. So what is the, Grace is asking, what is a good score? Any score above 15 is excellent. Okay. So this is dagger sign. Dagger sign, you can see this calcification, a line in the center of the spinal column. This occurs because of the calcification of the supraspinous ligament and the interspinous ligaments. Okay. Because of that, you get this straight line. And this is your bamboo spine. Now, Anuj was asking earlier the differences between a patella fracture and bipartite patella. I'll just quickly tell you. See, bipartite patella is a condition where the patella fuses as or develops as two different fragments. And finally, they will unite together by a cartilaginous joint or a synchondrosis. And because that synchondrosis will not be visible on X-ray, it looks like a fracture. So how will you differentiate it from a fracture? So I'll just draw a picture and show you the differences. Okay. First and foremost, in bipartite patella, you get a fracture or a radiolucent line like this, which is curved and in the suprolateral. It will be in the suprolateral corner. It is almost impossible to get a fracture in the suprolateral corner. Usually fracture would be like this. Okay. And you should look at the line. Here you can clearly see nice smooth lines. But in the case of fracture, it would be very ragged and jagged like this. Okay. Then the orientation in the case of bipartite patella would be in the supralateral area. In the case of patella fracture, it could be transverse like this, or sometimes it can be comminuted like this, but never in the supralateral corner. But the classical sign would be clinical. Bipartite patella is completely asymptomatic. It is a normal variant. There won't be any symptoms. Here, if there is a fracture, the patient will have severe pain. There will be history of trauma also, isn't it? Now, if you want to confirm, very easy, take the X-ray of the opposite limb. Bipartite patella would be bilateral. So, the other side will also have the similar change. Okay. So, that is how you differentiate. All right then. So if you have any further doubts, you can ask me. So shall we wind up? Okay. So we'll wind up this session. So all the best for your upcoming exam. And if you have any further doubts, you can definitely contact me. Yeah. So I'll just put down my number here. You can WhatsApp me any doubts. Whatever doubts you ask me, I will always respond. Okay. So you can ask me any doubts on WhatsApp at this number. And all the best. One important point, please don't lose focus. Okay. Forget about the next date and all. Go study. That's it. So all the best. Good night.
Recording stopped.
Sir, thank you, sir. Sir, please join the faculty meet.
Okay.